Good afternoon, everyone. Can everyone see us?
Yes.
Yes. Okay, great. Okay, welcome everyone to this session. We are in the Continuum of Care for Wasting session, and I'm Andi Kendle. And Martha.
And Andi. Can you hear me?
Yes, we can hear you. Go ahead.
Thank you. And I'm Martha, the CMAM advisor with the GNC Technical Alliance support team.
Great. And I am the technical support team coordinator for the GNC Technical Alliance. Great. We are the facilitators for today's session. Over to you, Martha, for this bit.
Thank you. Today we'll be looking at two. Can you hear me? I seem to have a problem connecting.
We can hear you.
Hello. Hello.
We can hear you, Martha.
Oh, thank you. I am frozen. I don't know what's happening my side.
Okay, I will continue, no problem. So today we are looking at two different aspects of continuum of care. The first is the management of small and at-risk infants under 6 months and their mothers. This will be done by Eleanor Rogers and Marie McGrath from ENN. And the second is on linking to services for moderate wasting, which will be presented by Nicolas Joannic from WFP. This will be followed by a Q&A session. Before we go ahead, I'd like to point out a few practical points about how this session works. If you have any questions that you want to be handled during the Q&A session, then you'll click on the Q&A button at the top right-hand side of your screen. You'll see where all the chat is. Above on that top left, it says Q&A. You put your questions there. If you're having any technical difficulties or would like to chat with your fellow participants, then you click on the chat button and you can speak to everyone. Write any comments you like, but those things will not necessarily be addressed during the Q&A session at the end. So basically, the session is good. We've got the session first on MAMI from Eleanor Rogers. And Marie McGrath will be in the background and available to during the Q&A session. So first, to tell you a little bit about Eleanor, she is the MAMI Global Network Coordinator, working on formalizing and scaling up the MAMI network to strengthen evidence, policy, and practice for the management of small and nutritionally at-risk infants under 6 months of age and their mothers. She's previously worked on CMAM for UNICEF, Action Against Hunger, the Coverage Monitoring Network, as well as an independent consultant working in East and Southern Africa, South Asia, East Asia, and Pacific regions. I'm going to tell you a little bit about Marie as well, although she won't be presenting. She's definitely behind the scenes and will be there for the Q&A. Marie is a technical director at ENN. She's a co-chair of the MAMI Global Network Steering Committee and ENN's lead on the process evaluation of the upcoming randomized control trial in Ethiopia, which is a partnership between the London School of Hygiene and Tropical Medicine, GOL, and Jimma University. She's been one of the key driving forces behind the MAMI work since its inception in 2008. She's also chair of the advisory board of the Eleanor Crook Foundation, coordinator of the IV Core Group. She also co-chairs the Wasting Global Thematic Working Group of the GNC Technical Alliance and a member of the Council of Research on Technical Advice on Severe Acute Malnutrition, otherwise known as CORTISAM, of the No Wasted Lives Consortium. As we intended for Eleanor to present first, but we're having some technical difficulties, I'm going to go ahead and present to tell you a little bit about Nicolas from WFP, who will actually present first. I hope that's okay with you, Nicolas. So Nicolas, he's the Chief Nutrition Operations in the Nutrition Division of WFP. Nicolas is a public health nutritionist, graduated from the University of Pharmacy of, I'm going to say this wrong, Rennes, and University of Medicine of Montpellier in France. Apologies for my bad pronunciation in French. Nicolas joined WFP Nutrition Division in 2017 after close to 15 years managing WFP nutrition programs in fragile and conflict-affected states. As Chief Nutrition Operations at WFP Nutrition Division in Rome, he leads WFP work at global level in nutrition emergencies, the nutrition supply chain, inclusive nutrition operations, and malnutrition treatment and prevention with a focus on fragile settings. He is one of the artisans of the new UNICEF WFP partnership framework on addressing wasting globally. He's a member of the Global Action Plan on Child Wasting Steering Committee and represents WFP in the GNC SAG. He also supports the development and scaling up of radically improved solutions to increase coverage of wasting prevention and treatment, which is at the core of WFP's engagement. Now I would like to hand over to Nicolas for the first presentation. Thank you.
Trying to share my screen, it's coming. I'm sorry, Andi, I cannot see my screen. If you have the presentation and if you can share it on the, that will be super helpful.
I will go ahead and share my screen. Tell me when you can see it.
Yes.
Hang on, I'm going to go back to the first slide. There we go.
Thank you very much.
You're welcome. Over to you.
Yes, if you can put it on the slide mode.
Great. Okay. Do you want to go to the first one or?
Yeah, but can you put it on the presentation mode?
It is. Can you not see it?
No.
Okay, let's try again. Hang on just a second. Is that better? Nicolas, can you see it?
No.
Okay. Can you can see it in not slide mode?
I don't see it at all.
Okay. Maybe I think it unshared. Just a second. Apologies, everyone. Okay. Can you see it now?
Yes,
can everyone see it?
Yes, but not in slide mode.
Again, not. Okay.
Slideshow.
You can see it. You can see it at all?
In edit mode.
Okay. I've got it on screen share. And can you see the second slide right now in edit mode or not? Okay.
We tried and it worked.
It did work. Okay, we're gonna just try again. You can see it now in edit mode.
Yes.
Maybe worthwhile starting anyway in edit mode if we can't get it into other mode.
Yeah, I'm not sure that the people will see the slide, but okay, so maybe we can just start. So first, Just would like to thank you, the organizers of this conference, to give an opportunity to talk a little bit about treatment of moderate wasting, because treatment of moderate wasting is an integral to CMAM, but somehow has been overlooked in the past decades, and the discussion and the global debates really focusing on treatment of severe form of wasting, much more than on the treatment of moderate form of wasting. So maybe just to start to remind, I mean, I feel it is important to remind here why it is important to consider also treatment of moderate wasting in children under 5. Because all degrees of anthropometric deficits are associated with increased risk of mortality in children under 5, not only severe wasting, and the same way also moderately wasted children have heightened risk of morbidity and significantly more mortality compared with the healthy pairs. And also, I mean, there is a growing body of evidence that an important proportion of children with moderate wasting would fail to recover without specific intervention, and not only in food insecure area, but also in more food secure context. And also there is also more and more evidence that show that spontaneous recovery is limited. So for the past almost 60 years, I mean, since we started, since the international community, nutrition community started to address the issue of wasting, the focus was mainly on the treatment of severe forms of malnutrition, and little attention given to the moderate forms of wasting and its consequences on child survival and development. Just to remind here that the first revolution in the management of severe malnutrition occurs in the mid-90s with the introduction of specialized MIC and improved protocol introduced by World Health Organization in 1991, and also the CTC model. The second very critical evolution in the management of wasting occurred at the beginning of 20 with the rollout of the decentralized community-based model involving the use of ready-to-use food. And this revolutionary approach involves the management of acute malnutrition within the community following a period of sensitization and mobilization. And the primary aim of the decentralization of treatment was to improve the coverage of treatment beyond those levels achieved with the center-based program. It is only in 2007 that with the first joint FAO, UNICEF, WFP statement on acute malnutrition that and that was later on followed by the MOU between WFP and UNICEF, that international nutrition community started to give more attention to both forms of acute malnutrition, and a clear division of labor between WFP and UNICEF in the treatment and prevention of acute malnutrition was defined. In 2017, the Global Nutrition Cluster issued the MAM decision toolkit, whose recommendation apply mainly to emergency settings. And so nowadays, the commitment to child nutrition treatment of wasting in children by national government is in over 70 countries, and that has led to the adoption of national protocol to treat acute malnutrition based on existing WHO recommendation. But that's a matter of fact, there is no normative guidelines that have been produced by WHO for MAM treatment. And it's only, I mean, in 2020 that now WHO has started the development of a new wasting guidelines that will include, hopefully, some recommendation for the treatment of and prevention of moderate wasting. Next slide. So as we speak, I mean, there is about 40 countries where WFP operates, where MAM, there is provision in national treatment protocol for MAM treatment. Just to give you some idea about the scale of MAM treatment operation from a WFP perspective, because there are also other players that support the delivery of MAM treatment services, but WFP remaining the largest supporter of MAM treatment worldwide. In 2020, we treated approximately 6.5 million children with moderate wasting. And also we scaled up also the prevention program targeting children and pregnant and lactating women. And 80% of everything that we do is in a humanitarian and fragile context. Next slide. Okay, so now I just would like to talk a little bit more about the challenges that we are facing in scaling up and integrating MAM treatment program. And I will start by describing some of the systemic issues that that are reported by our colleagues in the field and that we are also observing here from the global level. And the first bucket of issues speak about funding and capacity. In many settings, the implementation of CMAM or national guidance for the treatment of child wasting faces challenges, and including and owing to limited resources and capacity, which hamper efforts to treat all children in need. Progress were made to integrate MAM treatment into national services, but there are still a lot to do to ensure systematic inclusion of MAM treatment in national protocol to be delivered through existing health services. In many fragile and conflict-affected states where WFP usually operates, systems are often dysfunctional, have collapsed or are non-existent, and that leaves many nutritionally vulnerable children and women beyond the reach of basic health and social care. Then, I mean, despite progress on the funding side, the availability of funding does not cover all the needs. And the national contribution, the budget allocated for by national governments to treatment of wasting are growing, yet scale up is constrained by this limited funding, and very often the funding rely on external and unsustainable sources. Also, funding cycles are often on short term and really focus on emergency. A lot of donors provide geographical earmarking funding, and that does not also help to scale up coverage of MAM treatment in all the places where there are needs. In addition to that, not all stakeholders, including, I mean, NGO, UN, donors, support all CMAM component. I mean, when I talk about CMAM, I include treatment of SAM, treatment of MAM, and prevention. Depending on the context, some donors fund only treatment of severe wasting, and some partners will implement only treatment of severe wasting. On the other side, some NGO focus only on the implementation of moderate wasting treatment or prevention, but not SAM treatment. And finding one partner to implement all activity across a complete prevention treatment continuum, and to do so at scale, is unlikely in most contexts. So that's one. And in terms of capacity also, many health workers, nutrition program staff, and community volunteers have received and continue to receive training on CMAM. But this capacity building requires really a lot of support and takes a lot of time, and especially in resource poor or where, I mean, literacy level is low. And the outcome of this investment in strengthening the capacity of national systems and community workers is a longer term outcome. So on the immediate term, we won't necessarily see the benefits of this investment on the scaling up and improve efficiency of MAM treatment coverage. Another aspect also on the systemic level, it's about the nutrition information system, which remain quite weak. Despite progress in national ownership, weak nutrition information system really hinder the availability of timely, quality, and reliable program data. And also that is an area that require ongoing capacity and continued capacity strengthening. Then when it comes to the design and the implementation of CMAM within the continuum of care, there are also a number of bottlenecks that should be acknowledged within the current system and protocols to treat children. Achieving the continuum of care for wasting means that any child receives the appropriate timely care to enable full recovery wherever they're present along the wasting spectrum. So completely continuum. Now go back to the previous slide. So the complete continuum of care for wasting can only be secured by alignment with prevention program, as well as integration of services within health systems, and starting from the communities. But the importance of the community engagement that form the basis of CMAM has largely been underplayed or even ignored for the past decades. And this is where the greatest gain and most immediate gains in terms of coverage can be achieved moving on. And so the attention to community of care is especially critical when there is service deliveries through more than one program or access points, requiring a coherent and effective transition between services. But despite progress over the past year, I mean, there are still poor linkages between health centers and community-based services, poor and ineffective continuum of treatment between MAM and SAM, and the design of program is largely based on needs rather than on demand from the community, and there is lack of synergy between the treatment and prevention program. Next slide. Then, in terms of access and coverage, that's also an issue that we wanted to focus on, because in many fragile and conflict-affected situations, systems are so dysfunctional, and that leaves a lot of a community that are in need of services beyond the reach of basic health and social care. And just a statistic that really strikes me. I mean, according to the 2019 WHO evaluation report on progress towards universal health coverage, an estimated 1/3 to half of the world's population have essential health services coverage, with poorest and conflict-affected countries faring worse, between 12 to 27%. And yet this country is where, I mean, where the world health indicator, the worst health indicators are. With 80% of the epidemics, half of the child under 5 deaths, and more than 1/3 of maternal deaths reported occurring in this fragile and conflicted assistance. So the increasing focus on health center treatment should be questioned. And meanwhile, investment in community, which form the premises of CMAM, has largely, as I said, already been neglected and if not ignored for the past 2 decades. So if we continue at the same trends at the same pace to 2013, still according to WHO, only 39 to 63% of the global population will be covered by essential health services, and much less in conflict and fragile and conflict-affected states. So that's something also to really consider. In addition to that, there are also the opportunity and economic cost for the affected families and health service providers alike. These costs are often unaffordable, and the result that our treatment programs are often low coverage and high default rate. That's why new service delivery model adapted to each context or typology are urgently needed to reach a large population of proportion of population in need that do not have access to basic health care, especially in fragile context. Next slide. Next slide, please. Yeah. Also, we just wanted to touch on alternatives to specialized nutrition for treatment of moderate wasting, as we do acknowledge that it's not on all contexts that the distribution of specialized nutrition for the treatment of wasting is required. That should be determined based on multiple factors, risk factors at population level, to decide whether or not inclusion of SNF in MAM care or MAM treatment is required. I just wanted to report on a systematic review of the treatment of moderate malnutrition using food products that found that out of the 11 studies in this review, food product resulted in greater gains than counseling or micronutrient intervention. So at the moment, there is not really solid evidence that say that locally available food product achieve greater nutritional outcomes on MAM children than specialized nutritious food. That is a field of exploration, and we do believe that in contexts where nutritious, locally available nutritious food are available locally, that is something we need to consider, to especially if there is a deliberate aim at achieving universal care and treatment for all MAM kids, and that is a way also we need to build evidence around and to be able to achieve this objective. Next slide. So what are some of the key enablers that we do see to scaling up treatment of moderate wasting in fragile settings? The first one is really to change the mindset. So we believe that it is happening now, or since recently, and to move away from the MAM-SAM dichotomy. We need to consider MAM and SAM together to ensure the continuity of treatment and between MAM and SAM, and stop siloing treatment of MAM and SAM. This is absolutely key to make sure that wherever there is provision of SAM treatment services, there are also provision of MAM treatment services, and vice versa. A second very key enabler is to aim openly, deliberately for universal treatment and care coverage for all forms of malnutrition, whether it takes distribution of SNF or not. But we should agree that on this target. It has not been the case for the past 8 years. And yeah, just 2 minutes. Another key enablers is what we call localization of wasting treatment. And localization has different meanings. The first one is that there is no one-size-fits-all approach, and we need to adapt delivery of services to the specificities of each context, to better take into account the demand from the communities. That also means decentralizing the delivery of services to the community, to make this service available to the communities in a way to go back to the premises of CTC. And that means also building the capacity of local actors, communities, civil society, private sector, to gain, to improve or make gain in terms of coverage and address inefficiency in wasting treatment delivery. And finally, we do believe that wasting is not only a health condition, it is a social condition. And the treatment of wasting requires the contribution from more than health system only. It requires the contribution from social protection system and food system. And for the Q&A session, we can expand on that. Next slide. Yeah, just to highlight, to share 2 examples where we have managed to successfully scale up treatment of wasting using 2 very different approaches. In Cameroon, we decided to put prevention first and to integrate delivery of MAM treatment within a prevention approach. And thanks to the reach of our prevention program, we've managed to double the number of children reached, and that was a success. Also, we've managed to reduce the cost of the delivery of services to children by half. Another type of approach that we've implemented is in South Sudan, Yemen, and Somalia, is really to work with UNICEF and other counterparts, other stakeholders, to ensure the co-location of services. And now, just to give you an example, in South Sudan, 97% of MAM and SAM treatment are co-located, compared to 45% in 2014, and we have increased the number of children reached by 2.6. So I think we can stop here. Thank you, Andi, and thank you for your attention.
Wonderful. Thank you very much, Nicolas. Martha, are you able to jump on for a sec?
Yes, I am. Thank you. Thank you, Nicolas, for that very good presentation. Now, because of time, we'll straight away invite Eleanor to take us through the presentation on MAMI. Thank you, Eleanor.
Great, thank you. So good morning, good afternoon, everyone. I'm Eleanor Rogers. I'm the coordinator of the MAMI Global Network. And I'm going to talk to you about MAMI, which is the management of small and nutritionally at-risk infants under 6 months of age and their mothers. So I just want to start by thanking Concern and Irish Aid for inviting us to be part of this conference. So in the presentation, I'm going to look at a little bit of what is the problem that we perceive and what is our proposed solution to that, and then look at scale up. So where are we in the process of scale up? What are our priority actions? And then how can you all get involved? So slide, please. So first of all, what is the problem? So we know that small and nutritionally at-risk infants under 6 months of age are at higher risk of mortality and morbidity than their well-grown, well-nourished counterparts. Level, we identify these infants as those that are underweight, wasted, stunted, and low birth weight, and a combination of these. So in this DHS survey analysis from 54 countries, we found a global prevalence of underweight of 20%, wasted 21%, stunted nearly 18%, and also again with low birth weight, nearly 18%. So why is this happening? So we identified 3 sort of key hits that are causing this. So the first one is hit 1, which is in utero. So those are the infants that are born with a low birth weight. The second one are those infants that become malnourished in early infancy. And then the third is sort of suboptimal treatment and management of these infants. So between 0 to 6 months, there is a bit of a care gap. And so we consider this to be a sort of Goldilocks zone for intervention. So slide, please. So what is the solution that we have? So we have a vision for MAMI that every small and nutritionally at-risk infant under 6 months and their mother is supported to survive and thrive. So to enable this to happen, we've developed the MAMI Care Pathway. I'm not going to go into details on this approach, but I'll just give you a brief overview. So this will be released in a few weeks, and an orientation webinar will be available soon after. So we're applying an integrated care pathway approach to manage clinical issues, infant feeding problems, growth faltering, and maternal mental health across community, primary, secondary, and tertiary health services. So this care pathway, the aim of it really is to reduce the risk of death, so improve infant survival, but also to support the mother-infant pair to thrive. If you look at this image of the care pathway, don't worry, it's very small. I'm not expecting you to read the details, but there are distinct phases. So on the left-hand side, we have screening, then moves to assessment, and then management and support at inpatient and outpatient level, and then exit at 6 months of age once the infant reaches that, and referral to additional services if required. And really the core contents of the pathway are based on and intended to help operationalize WHO guidelines for the management of infants under 6 months with severe acute malnutrition, and those were from 2013. The approach is really focused on these high-risk infants, but providing them with tailored support, primarily counselling. But the key part of that is that it also links really closely with prevention and primary care services, so OATF programs. So those are the low risk, it's the entry into the health system if they're not already in it. The overall approach of the MAMI Care Pathway and the format is really aligned and modelled on IMCI. So I'll just give you a few key principles of the approach. So first of all, it bridges interventions. So we're really looking to bridge nutrition, health, mental health, reproductive health, and early childhood development. It also uses existing health system contact points. So if you're already screening for older infants in the community, we would then use that same contact point to identify these vulnerable infants and their mothers. It strengthens existing health and nutrition services. So it's really about focusing on what you've already got available in your health system and how can you use that to develop MAMI, to deliver MAMI. Also, it connects to other relevant services through referral pathways. So this is really important. It's about not only having a really good continuum of care from pregnancy and birth through to 6 months and beyond, but also to make sure that you're referring to other services that might be of value to that mother-infant pair. And we think that this is really a win-win for coverage. And the last point, but essential point, is this care pathway has to be adapted to your context. So this isn't an off-the-shelf toolkit, but it's an approach that can be adapted to the specific context that you work in. So that's a brief overview of the approach. Slide, please. So what's next in terms of scaling up for MAMI? So if we want to scale up, we know that we have to think about it from the beginning. So we use the MSI scaling up framework, and you can see there are 3 key steps. So the first one being design for scale, and then establish preconditions for scale and manage the scaling process. And we think with MAMI at the moment, we're somewhere between step 1 and 2. So between design for scale and establishing preconditions. So for example, we're in the process of filling information gaps, but also legitimizing change. Slide, please. So what does that actually mean in practice? Where are we? So first of all, we understand the problem. We know that after 10 years of work on this, plus there's a high burden of these vulnerable infants, but also we know there's limited existing services to address and support them. We've also defined success. So we have a vision for MAMI, but also for MAMI at scale. So in brief, our vision for MAMI at scale is the integration of MAMI within existing health facility and community services. We also have a proposed approach, so the MAMI care pathway, which I outlined at the start of this presentation. And we've really learned in terms of that approach for scale, we've learned from CMAM. So for example, we know that we need to embed and integrate the MAMI package in wider health systems right from the start to actually have sustainability at scale. We also know we need to invest heavily in community delivery and ensure that the community is involved from the start. Number 4 thing is that we have an evidence agenda. So again, something we've learned from CMAM is the importance of a really strong evidence agenda. And this is not just on the effectiveness of the approach, but also in terms of better understanding the target group. We have a leadership mechanism, so that's the MAMI Global Network. And we have a very clear vision and mission for the network, which is available on our website or in our booth. And the network's focused on 3 key areas. So that's on evidence, policy, and practice. I'm really focused on getting that evidence into policy and practice. And last, we're engaged with key actors and processes to influence policy. And that's really important to make sure we influence national and international policy to facilitate scale up. Slide, please. So what are the next steps in the scale-up process? So at the MAMI Global Network, we're going to continue to lead from the front. So we think this is really important and a lot of where our value lies. So first of all, that means sharing the vision widely outside of the network with a whole range of stakeholders. So if people don't know what we want to achieve, we'll really struggle to achieve it. We also need to expand the network. So we want to make sure that we've got a range of voices that are represented and heard. We want to identify and support MAMI champions, and also sharing the care pathway resource package widely across stakeholders, but also across sectors. We also need strong evidence. So we have the evidence agenda, and now we need to go about gaining that evidence. So the MAMI care pathway package needs to be tested. And we're really seeing evidence along a spectrum. So we want robust evidence in the form of trials in different contexts, but also equally important is to have consistent high quality implementation research and strong documentation of programming. So for example, one partner activity is a RCT in Ethiopia to test the efficacy of the package. And that's through implementation by an NGO, but also implementation through the health system. So that work is being led by LSHTM in collaboration with Jimma University and GOAL and ENN. But also, this is where you come in. We really encourage all partners to test the approach across development and humanitarian contexts. We also need further research on the target group. So there's been some fantastic research that's improved our understanding over the last 10 years. For example, some work in Kenya looking at anthropometric indicators of risk. But we've got more to learn. And I think it's worth noting that all of these research priorities align with those in the Global Action Plan for Child's Wasting Research Agenda. And last, we need to engage with key actors and processes to influence action and policy. So as I mentioned, the gap for wasting is very significant. UNICEF's 2020-2030 nutrition strategy now focuses on wasting in children 0 to 2 years, so under 6 months is obviously a key part of that. But also WHO are updating their guidelines for wasting, and that include infants under 6 months. So we need to make sure we're actively supporting all of these agendas. Slide, please. So just very quickly look at some barriers and enablers. So first of all, there is a bit of a nutrition and health divide in service delivery, and we need to make sure in MAMI that we're bridging that. And it's particularly important because with these very young infants, making sure you've got close links with reproductive health as well as maternal mental health is really essential. There's currently a bit of a limited continuum of care, so we need to make sure that we're linking with those pregnancy and services at birth to identify these small and nutritionally at-risk infants, but also once infants get to 6 months of age, that the mother and the infant are referred to further services such as community-based wasting services if they need to be. Another thing is that integration is a challenge. We know from CMAM that integration is a real challenge, and we're not pretending that it's going to be easy necessarily with MAMI, but we know that we need to think about it really from the start. And then last, there is perhaps a bit of an overemphasis on anthropometry and nutrition, and it is a very useful tool, but we want to make sure in MAMI that we're considering growth faltering and the causes of growth faltering to inform screening, assessment, management, and monitoring. There are also some enablers. So again, we've got very good recognition of the issue. So in the most recent Lancet papers, there was recognition of the burden of infants under 6 months, but also there is a recognition of the need to manage small and nutritionally at-risk infants better. There is a current IMCI guideline update, and it's a good opportunity to include some key MAMI actions in that. Another point is that this is a very low risk approach, so the focus is really on counselling for and monitoring of growth and clinical issues and infant feeding, also maternal mental health. And last, this approach does build on existing services. So we really think that this is an enabler because you can take action now. You can look at what you've got and take action. Slide, please. So what can you do to facilitate the MAMI vision? So we're really relying on this being a team effort. So we really want you to be involved with us and join the conversation. So at the MAMI Global Network, please come and join our work, and you can send us an email on this link, and that was also available in our booth. And it's a great opportunity as well for you to link up with a range of experts from a variety of contexts. We can't claim to know all of the answers, so we're really relying on you all to be part of this. We also think it's important to start considering the size of the problem in your context. So what is the burden, but also what are the key causal factors for small and nutritionally at-risk infants? And understanding the size of the problem is really the first step in being able to address it. We would love you to review the MAMI Care Pathway Resource Package when that's released, so that will be in the coming weeks. And as I mentioned, there will be a webinar as well. So if you could have a look at it, and even feedback at this stage is really valuable. But then thinking about how you might use it in your context. And then the last thing is to test. Please test this approach. And that's not only formal research, but also implementation research in a range of contexts. It's really important. And please collaborate as well as doing this. And also, please do share your findings, but also any adaptations you've made or any tools you've developed so that we can learn from them, but also so that we share them with others to learn from them. So thank you so much. That's the end of my presentation. And I look forward to answering any questions along with my colleague, Marie McGrath, who'll be joining.
Thank you, Eleanor. Thank you so much for your presentation. We have very limited time left, so we'll have a couple of questions. That's 2 to 3 questions. And given that we have MAMI fresh in our minds, I will suggest that we start with the question of MAMI. This is a question that was sent in from Colin and from Pat. He's wondering whether, due to increased needs of the mother during breastfeeding, if the MAMI care pathway includes maternal nutrition intervention.
I can address that. Thank you, Pat, for the question. I responded on the chat, but I'm not sure if it went out to everybody. Just to say, as you rightly reflect, maternal nutrition and health during pregnancy is critical to a mother's health herself, and for that of her infant and outcomes. At the moment, within the MAMI Global Network, we have focused and prioritised the 0 to 6 months of age and the mother's care in that regard, because it's a huge burden and care gap there is, and a lack of continuum of care. But our vision is very much to encompass and work backwards to eventually include what we can do with maternal nutrition and health during pregnancy. And certainly that's our kind of priority area of attention, but it won't be our sole one. And indeed, there is nothing to stop anyone connecting in and linking in with maternal nutrition and health during pregnancy. And we very much welcome any initiatives and efforts people are engaged with to do all of that, because much of what we've learned and what we've been developed has been through people implementing and trying programs. And that's where the rich learning happens on the ground. So we welcome any initiatives in that regard.
Thank you. I have a question for Nicola. Pat was asking whether the low coverage rate for severe wasting, due primarily to funding and policy, is the reason why moderate wasting has not been prioritized. Nicola, that's a question for you.
I'm not sure that he's still here. I can't see him. So perhaps if you can swap to a question for MAMI for the moment, we can see if we can get him back.
Okay, great. We'll definitely answer these questions in following up during the ongoing discussions. There is another question, and maybe Elena or Marie can give us a response. Colin says that they have found field teams feel overwhelmed by the current MAMI tool, especially as they consider how to implement it within the context of other programs. And so she's wondering if there's any advice on how to overcome this initial impression, and if the framing of the MAMI care pathway will help with this.
Yeah, I think some of the feedback that we had previously from the version 1 and 2 of the tool was that it was quite overwhelming, and it was perhaps a lot for health workers to manage. But in this care pathway, we've really tried to simplify everything a lot, and really tried to make it much more user-friendly. But also, I think the important thing to note is that this is a blueprint for care. So it's really important that people are taking this and making it workable in their context. So we have a lot to learn from that as well. So we want to make sure that we have that feedback mechanism as well. If this is too overwhelming for health workers, how have you overcome that in your context?
In addition, to other challenges, there's another question coming in from Park, and he's asking whether you're getting as much support from other ministries that are not the Ministry of Health, for example, in countries or contexts where there are maternal mental health or maternal health is part of the Ministry of Gender or Education.
I can speak to that, and I think also there's a related question I think that had come in asking about whether we've got buy-in from governments as well, or experience with individual country level support. So I guess they're connected. I think in our scaling up of the MAMI Global Network from what was a very informal special interest group, part of our reason and vision for doing that is much closer direct engagement with national stakeholders. So we've just formed a steering committee, which is representation from India, Ethiopia, Uganda, and Kenya, and including Ministry of Health. So we see them, these key stakeholders, as key to our direction and vision and delivery, our evidence generation. Very much we want to look at what evidence countries need at national level in order to inform their policy, and that we use that to inform what we do at a global level, rather than vice versa, and us decide what's needed at global level and then try and have that trickle down. We've got very strong engagement in Ethiopia, and the evidence that Eleanor mentioned in terms of the research that's been planned in Ethiopia very much speaks to national Ethiopian priorities for evidence to inform their policy. We've also got very good engagement with India, and very much we are being driven by what their agenda is, and they are driving our agenda, not the vice versa. We've also other examples from Uganda as well, where guidelines have been updated to reflect MAMI within guidance. But I think what we've found that the key barrier to uptake of this approach at country level is that governments are rightly saying we need more evidence on if it works and how it works in our particular context. And this is critical. They want to know what are the implications in terms of capacity, but also what are the opportunities. So that's the type of research that we are looking at in Ethiopia, and we really welcome and encourage you to build that evidence, but that it needs to come from a national level, be nationally driven. And this network that we are involved with, the MAMI Global Network, it's not one of strict membership. It's a community and a collective of practitioners open to all. And we really, really do want multi-stakeholder and national representation at its heart.
Oh, you're on mute, Martha.
Oh, sorry, thank you very much. We have one last question as we come to the end. Honor is asking why the focus of MAMI has been narrowed to small and nutritionally at-risk infants, yet there are those infants who are born normal or do not have any issues but are likely to have malnutrition or have complications due to health and social factors. And in that same sense, asks whether MAMI shouldn't be seen within the perspective of the first 1,000 days.
Yeah, sure. So, I mean, I guess we term them small and nutritionally at-risk infants, but the screening criteria are quite broad. So I'd hope that we're identifying that there are those that are very born small, but also those that will become malnourished in infancy in the first 6 months of life. So we want to really emphasize that we hope that we expect this approach to identify those infants and to provide them with the support that they need to survive and thrive.
Thank you very much. We have run out of time, unfortunately. There's so many interesting questions, but we'll continue throughout the discussions. Andi, over to you.
Thank you. Thank you, Marie. Thank you, Eleanor. Thank you, Martha. Thank you, Nicolas. But Nicolas unfortunately had to go on to the panel discussion. So it's a perfect opportunity, well, first to apologize that he is not here to answer your questions, but he is there. So you can ask questions there. And also feel free to drop questions for him into the moderate wasting discussion room. So right now we need to end. We've finished our time, but you can now join the panel discussion. The final session of the day on the main stage is starting in 5 minutes, and you can access that from the agenda and information tab on the left-hand side of your screen. So I want to thank all the participants for attending and all the presenters very much for your informative presentations. And we're looking forward to seeing MAMI thriving and moving forward, just as the kids that are under 6 months with their mothers, and looking to see how we can ensure that MAM is also treated in a more holistic way, looking at community and how we can ensure to scale it up as best we can. Looking forward to see you later. Thanks a lot. Enjoy your afternoon, evening,
Thank you.
day.